this is essentially for you guys. And because we've made a lot of progress in newly diagnosed setting, we're still trying to understand a lot about how different patients need to be approached in different ways, whether it's because of the kind of myeloma they have or the other, health condition baggage that patients bring with them. Because we have to start looking at myeloma treatment in a more holistic fashion, and so that's kind of the goal for us moving forward. When we did not have good treatment options, when the survival outcomes for myeloma was not the way they are today, the proposition was a little different. So, quality of life becomes important, safety becomes important, and we have to put all of those elements together. So with that is all I'm going to share right now. This is kind of like an icebreaker moment. So I'm just blabbering so that everyone gets comfortable and they can start asking questions. But I'm happy to field any questions. We're supposed to focus on newly diagnosed myeloma, but you can ask me anything, and I'm happy to provide answers. I've been taking care of myeloma patients for 18 years. I started as a trainee. When I was doing my fellowship training, I wanted to be a breast cancer researcher. But within a few months of joining my fellowship program, I just gravitated towards blood cancers and myeloma specifically, ended up doing more than 2 years of lab research, and that took me to the University of Arkansas, which was the mecca of myeloma research at that time, and one of the godfathers of the field, Dr. Bart Barloghi, became my mentor. And a lot of advances we made in the field in terms of understanding the disease biology, developing new treatments. The frontline approaches we use for myeloma patients today, they're regimens that I helped develop in clinical trials, and so I've been very much involved in all that research, and I've set up programs in the South that are doing extremely well. And I've been in New York now for 3+ years, and building the myeloma program here. It's a huge team, and several members are here today, and other work that we're doing I'll share. That's it. I was just trying to kill time while other people join, but this is open mic time, so please, yes, sir.
If you have a question, I'll come and give you the microphone, just so it ends up on the video as well.
Oh, hi. This is Sunil Jain. My wife is a myeloma patient. What ratio of free chain ratio, free Lambda ratio is too high? What is considered too high?
Are you talking about myeloma that is requiring treatment, or?
No, when she goes for treatment, and before treatment, her blood is being checked. And then next day she get results on the email. There's one result the doctor always talked about, free Lambda ratio. So my question is, and she always tell me it's not to the level she would like to see.
Got it.
My question to you is, what free Lambda ratio is too high for the patient?
Okay. All right. Please take a seat, and I'll actually take a few steps back and explain, what we monitor in the blood, because every patient is different. So myeloma is a cancer of these immune cells called plasma cells. And plasma cells are a family of immune cells that make antibody or immunoglobulin proteins. From the time we are born onwards, we get exposed to many different things in our environment. Viruses, bacteria, allergens, things that we eat. The body's immune system can recognize what belongs to our body, and it can recognize what doesn't belong to the body. And what doesn't belong to the body, these immune cells start making antibodies or immunoglobulins against them. And that's the whole concept of vaccination. You give a vaccine, challenge the immune system to make antibodies so that the next time the virus or the bacteria actually attacks the body's immune system is ready to fight them. So it's those antibody proteins that these cells make. Now, what this antibody protein, what is the structure? it's shaped like a Y, and there is the inner part of that structure, of the Y structure, is called the heavy chain. It's the longer part. And there's a tiny short part called the light chain, okay? And that light chain is of two types, kappa and lambda. In a regular person who does not have myeloma, the kappa and lambda are produced almost in equal amounts. So the ratio between them, if the body, I'm just making this number up, if they're making 10 of kappa, 10 of lambda, the ratio is going to be 1. Or, it might be 15 and 9, but it's going to be somewhere, between 0.5 to 1.6, something like that. And when you have myeloma cells and they're overproducing one kind of immunoglobulin and light chain, then if it's kappa, it might be 200. Or lambda might be 200 and the kappa will be low. So the ratio between good and bad becomes disturbed. It becomes 10, 15, or 20. Okay, I'm just making these numbers up. So that number is going to be different from one patient to the next. So when you ask me the question, what ratio is good or bad, it really depends where her numbers started from and whether those light chains had an effect on the kidneys. Because these light chain proteins are recycled and managed by the kidneys. Anything that's in excess, kidneys are a very smart organ. They're charged with getting rid of salts or water that is excess that the body doesn't need, and the same is true for any excess protein that is made in the body. So every patient is going to be different. So I don't know the particulars of what's happening to you or the lambda light chains, but what the doctors are looking at is what was the total number of the lambda light chain and what was the ratio of good and bad. And we are watching these numbers together over time as patients are being treated. I hope this explanation makes more sense. I wanted to start with very basic things. Yeah. Yes, ma'am.
Hi, my name is Laura Mooney. I run a support group here in Staten Island, New York. And I'm noticing that I'm getting a lot of new young patients between the ages of 40 and 50. In fact, last month we had 3. So I'm wondering, are you seeing that? I mean, I know the average age now they're saying is 70, but what's happening with so many young people getting multiple myeloma? It's baffling.
Yeah, I think if we look at the national statistics, the proportion of patients who are under the age of 50 has not gone up in this decade or the last decade. But the fact that we have more awareness and patients are actually trying to learn more about this is the reason why you're probably seeing more participation in the support groups. And young people want to know. It's a little bit more of a generational thing as well. But I take care of a lot of myeloma patients, and especially patients who have more aggressive kind of myeloma. So I get to see a lot of young patients. So my views are a little skewed from that perspective as well. It's like you have a bunch of people with blindfolds, and we're trying to feel the elephant and describing what that elephant may look like to us. But if we look at the bigger picture, all the patients who are getting diagnosed in the United States, the proportion of people under the 50 has kind of stayed the same. Yeah. Yes, ma'am. Yeah, and then Terry, you're next, and then we'll.
Hi, good morning, everyone. So I was newly diagnosed with multiple myeloma, which this year, July. And just what the young lady just opened up, it's kind of a little frustrating to hear that age category, because I've heard the doctor, a doctor say that to me, like, it's not common for my age to be hit with multiple myeloma. And as I start seeing my research, I feel like that's inaccurate information. And I am so on point with my healthcare that I could kind of bottle it. Like, I'm a living donor, and I give blood every year. And about last year around, when I went to go donate blood at the bank, they didn't accept it. At that time, I was on my menstrual, And I had just recently were told that I'm anemic, and also that day I didn't eat. So for some reason, they kept sticking me, and it was like, no, you can't. And I experienced severe back pain, fatigue. At the time, I was 42, and I was like, it's just not normal that I can't get up out the bed. And I'm always tired, and I kept passing out. And as much as I kept telling my doctor, it was like the nurse practitioner who was seeing me for over 2 years, our relationship was just not a healthy relationship. I kept asking to be changed. I went from having private insurance to state insurance, and I just, you know when you get good care, and when I'm gonna say good care, meaning if I need an MRI, I'm gonna get an MRI in that month, not 6 months later, right? If I need a CT, if I need to see a cardiologist, whatever it is, and I was going through a severe of stuff that was just being ignored. It was only until one day when I tried to pick up a pot to make an item, and I couldn't pick the pot up, and I called someone to help me, and it was like, this is so light. And I said, everybody around me, my friends, I'm 43 now, they do these iron infusions. And I said, let me go get that. Go back to my doctor, and she's arguing with me about this. She's like, oh, you gotta wait for a week for a blood examination. For the blood to come back. I'm like, why? I'm used to doing blood and getting it the same day. So 2 days later, I get a call that my hemoglobin is low, and I could put this down here. I need to go and get a blood transfusion. And I'm like, okay, because I'm a busy person. I do a lot. I'm like, I'm going to go get this blood transfusion, and I'm going to leave. I walked into the hospital, and I didn't leave 5 days later. And they just, like, all the people kept seeing me. They kept saying the multiple myeloma, but it didn't hit. And they were just like, I was like, well, why no one said this to me before? They kept saying I had chronic pain, and they were giving me epidural shots in my back. And I had to come back a week later, and they told me that I had myeloma. And then they told me that I had it really bad and I needed chemo. I came back for chemo, and they wouldn't even give me my chemo because of the insurance situation. Finally, they started treating me. It was a horrible experience. Thank God for Hackensack. I was able to meet a wonderful doctor there, Dr. Poole, and she changed my life. When my first diagnosis happened, I have kids, I was just counting my days and how fast I could help my kids before I go. When I got to Hackensack, I could see 50 years. My future is beautiful. I just recently finished my transplant. I'm 4 weeks out, and I'm feeling really, really good. But my question today, I wasn't going to share that, but because she said about the age thing, it frustrated me because I felt like I could have got treated before. I went to everything that I've experienced with my diagnosis, it all matches up. And I even went back with my records, like look how much, the epidural shot, I had the shots, I had 7 medications that they were giving me, multiple relaxers, and I was still not doing well, and I was passing out. Those should have been signs to run the test that they needed to run. My question is, as I was doing my research and looking into my family, I saw that my aunt died from multiple myeloma. I also discovered that her daughter is now being tested every 2 months because she's anemic now. They said she's anemic. She has severe back pain. She's going through a lot of experience that I'm going through. So my question is, why? And my mom died of ovarian cancer stage 4. They're saying that it's not generic, like you can't inherit it. It's not something that runs in the past. But I feel like that's close. Aunt, my mom's sister, and now her daughter is experiencing what she's experienced, and then I experienced what I experienced. So do you see that happen?
Yeah, no, first of all, thank you for sharing your story. And no, it's all right. Your story resonates with me because I've taken care of patients in the same situation as you, who were fine, and because they're young, the diagnosis was made with a little bit of a delay because one does not expect people that young to have the disease, and there's a patient, his name is Tony Newburn. He's actually part of patient advocacy efforts on a national level now, but Tony was in his 30s when he presented. That was, and he had high-risk disease, but he presented with a lot of bone fractures in the back, inability to walk, kidney problems out of the blue. And this is a person who was a personal trainer, extremely fit, and just went downhill very quickly. And part of the issue during that initial diagnostic workup was no one was expecting that. So we understand this a little better than we did in the past, and thank you for sharing that story. I think we'll see less and less of that happening because myeloma therapies, myeloma survivorship is so different today than it used to be. To answer your question, the incidence of having a plasma cell problem is higher in folks of Black descent, of African descent than any other race. That's number one. Even the precursor condition that we call MGUS, or monoclonal gammopathy of undetermined significance, is higher. And we're still trying to understand whether it's because of immunology of people who have different race and ethnicity that makes this happen. How our bodies interact with the environment and the immune system reacts to it. And we know that MGUS is the precursor condition to folks developing myeloma. So if the incidence of MGUS is higher, then the incidence of likelihood of getting myeloma or amyloidosis is also higher. But majority of people who get MGUS will never develop myeloma or any other problem in their lifetimes. That's what we've learned. So there are families where you may have one family member who has MGUS, and with 1 degree of separation, someone may have it as well. And from what you're telling me, your cousin appears to have probably an MGUS kind of situation. That's why they're monitoring the blood work closely, so it's possible that there might be some immune system-specific issues where people develop MGUS more commonly, and we're just trying to understand that now. So this is not something genetic in terms of you were born with an abnormal cancer cells that declare themselves. It's how the immune system actually reacts to it, and then maybe there are a family of plasma cells that start developing abnormally as you get into your 20s, 30s, or 40s. There's in fact a study from blood samples collected in Nigeria, roughly 900 patients, 30 years or older, and serum protein electrophoresis or the protein studies were done on those patients. This is like normal population. And they found this MGUS abnormality even in folks who were in their early 30s. Okay, so this has been documented. There's a huge study happening right now in the country of Iceland. It's as white as it gets. It's a very homogeneous population. It's a small country. They only have like 400,000 people. That's like these 10 blocks here essentially. But they did a study where they screened people, half of the population. They did blood tests and looked at these protein levels. About 4 to 5% of them have it. So, but will they develop myeloma or a problem in the future? The likelihood is very low. Less than 15% will. So, so what I'm trying to tell you is that it has to do more with how your immune system reacts to things, and the way that my South Asian genes and immune system will react is going to be different from you, from different folks from different race and ethnicities.
Thank you.
Yep.
Hi, I introduced myself. I'm Terry. I also run a support group, and I have a lot of MSK people. So thank you for that. I have a twofold question because both of their questions made me think of this as well. But my first question is, and I'm asking more, I've been into this for 2 years now, so for the people that I talk to all the time, is the goal MRD negativity? How do you feel about that, and does it matter how you get there? If you become MRD negative before stem cell transplant, CAR T, whatever. So I'm interested in your take on MRD negativity. And then the other thing, I'm very interested in what she's saying and what Laura had said, is that how do we get primary care physicians and or orthopedic doctors to start paying attention to a story like that? I had asked a question on this social media site, and about 200 people have answered, and a lot of them, if they have protein in their blood, it seems to be caught very early, but a lot of these back pains and these other, like, how do we get those doctors to start paying attention?
So your first question I'm actually going to cover in my talk, and I'm going to take a deep dive in it. So I'm going to leave the MRD piece for that specific section, because I think MRD is just a test that tells us how deep a response is, and that's our new assessment of response essentially, and that's, it's always been about getting deep responses in myeloma, and MRD is just, a tool that we utilize to look at that, and I'll share more details about it. But it is important, it's not anything fancy, it's just now saying, we used to call complete responses based on blood test, and now it's MRD. That's what it is. It's not complicated. It's just the second question is more important. And I'll give a very, again, I'll share an anecdote. So I finished my internal medicine residency, in the mid-2000s. There was a book of internal medicine called Harrison's Book of Principles of Internal Medicine. It's the Bible of internal medicine. At that time, when I bought that book in 2003, the description for myeloma was a paragraph, and this is like a huge book, right? Did I get a board question about myeloma when I gave my internal medicine residency exam? No. So I take the boards and I decide to become an internal medicine doc. What are the most common things I'm going to see in my practice day in and day out? It's going to be high blood pressure, diabetes, heart disease, joint issues, infections, and then you're going to get cancer screening done, diagnose patients, send them to the right people. Myeloma makes up less than 2% of all cancers in the US. And now fast forward 20 years. I'm still in practice. I've been in practice for 2 decades now. My knowledge of myeloma, if I was a really good internal medicine resident, is this paragraph in the book of the Bible of internal medicine. Okay. And I've kept up with how to manage blood pressure, cholesterol issues, all of those things. But unless someone is proactively educating me about what's happening in the field, I'm not picking up on those things. So so what's happened in the field is, in the last 14 years, myeloma treatment has become very complicated because all of the therapies that we've added to our armamentarium. Even a regular hematologist oncologist cannot keep up with all the advances. And they continually text us, call us, okay, what are we doing? What do we need to do for our patients? And if something happens, what are the numbers we're looking at? And these are really good clinicians. These are excellent doctors, but so much is changing that they cannot keep up with things, and it's totally understandable. About 6 or 7 years ago, we started to have more engagement with our community colleagues, educating them, going to their conferences, telling them about all the wonderful things we're doing in the field. This is a partnership. Organizations like HealthTree, MMRF, IMF, even industry partners are trying to develop programs that will do that outreach, where we'd be able to go to internal medicine practices and explain things to them. When I moved from Arkansas to North Carolina back in 2013 to start a new department of hematology for this brand new cancer center and build the program in Charlotte, our catchment area was somewhere around 6 million. There wasn't a lot in North or South Carolina. Charlotte sits at the border of North and South Carolina. So there were a lot of community practices, huge healthcare systems, where people had been practicing for 15, 20 years. And so, we had to go out and educate people what to watch out for. And that's exactly what we need to continue to do. So that's the part of, the things that we can do, HealthTree can do, all the, patient advocacy organizations can do. What can you do as a patient? You can educate your primary care doctor. You can tell them, look at my example. So, and explain to them that this is what happened to me. There were delays in my, diagnosis. I feel, hindsight is 20/20, but I don't want this to happen to someone else. So, if you come across someone young who's having these symptoms, please think about myeloma. Okay, please work that patient up. And so I think it's, that, you have to do that reverse education for your primary care physicians as well. Sorry about the long answer. I talk a lot, so, sorry about that. Okay, yes, please.
My question is very specific. On the one test that looks at the bands, and I know mine came back saying capital light chain band, but then it also said something that oligoclonal, and when you go Dr. Google, it always says, oh, that's after treatment and everything, but I'm not. I'm newly diagnosed. So what are those? What does that relate to?
Yeah, so oligoclonal bands mean that, you have different immune cells that are making regular antibodies against different things, and sometimes the immunofixation picks them up. So, and they tend to be transient, they come and go. So if you had your vaccines, oligoclonal bands might show up, a week or two later. And then, your immunoglobulins may be high because of that, and then they'll settle down. If you have seasonal allergies, sometimes, you get oligoclonal bands from those kind of, issues. You might not be symptomatic, but maybe you picked up a virus from some, another person when you went to the grocery store. Your immune system took care of it, but guess what? The way that the immune system took care of it is by making some extra antibodies, and they might show up as oligoclonal bands. Not all of us are getting immunofixations checked regularly, but these things can show up. Yeah. Yes, sir.
Okay. Hi. So I have an interesting story. So I'm very early in the process, and I don't actually know what I have. But last year I had Coxsackie virus, and then the hand, foot, and mouth syndrome, and I had the brittle nails. And then, like they showed on the screen, GC5PRD mutation has the brittle nails and all the stuff with the hair and everything. But at that time, I convinced a medical practitioner to send heavy light chains, and my HLC lambda ratio was off. So more lambda, so it was low, but it's heavy light chain. IgM total was something elevated, like 301, with a normal that goes up to 172. But I know that for like Waldenstrom's or official MGUS, you need like 2,000 or something. There's a huge. So it's kind of like low, abnormal ratio, but not enough to be Waldenstrom's. And so then the year after, I was hospitalized with bad pericarditis, pericardial tamponade, the constriction band of pericarditis, huge pleural effusions. They took out a leader from around the right lung. There was another leader around the left lung, ascites, and bad proteinuria. I've had a kidney biopsy that's apparently completely normal, so I've seen more than 30, if not 40 physicians, and everybody's like, well, post-viral, maybe had Coxsackie pericarditis. But recently, I managed to get a peripheral blood flow cytometry, which said 0.01% plasma cells, but the cytoplasmic was 75% lambda, 25% kappa. So I just feel like something MGUS-ish is brewing inside me. And then ever since the pericarditis diagnosis is like, I have to take prednisone or methylprednisolone, and if I don't take it, the pleural effusions just come back. Then I take the prednisone again, pleural effusions come down. So I just don't know. Am I like self-treating a smoldering myeloma? So the answer is going to be in the bone marrow. But I guess my question would be, do you see sort of like a continuum with IgG4 disease? Some people say that IgG4 disease has a very small clonal plasma cell population, and then you kind of accumulate mutations, and you get MGUS, and then maybe if you accumulate more mutations, you actually get the full-blown.
Yeah, so I don't think there is an association, we haven't proven scientifically that there is any association with IgG4 disease and MGUS or myeloma. These are separate entities. But since I'm going to be answering this, to the whole, room here, let me just, kind of summarize things. So essentially the question being asked is, with the different things happening, with your clinical picture and immune system, is there a possibility that there is an MGUS or something that could be, causing or contributing to any of this? So, MGUS is very common. I just shared that in another response that, there are screening studies that have demonstrated that if you look deep enough, if you start doing mass spectrometry, which is a very sensitive method to detect abnormal proteins, you can detect abnormal proteins or 0.004% or whatever, plasma cells in 4 to 5 out of 100 people. So even in this room, if none of us, we're talking about a room with 50 people, who do not have a plasma cell problem, and we start doing blood work and biopsies, 2 to 3% of the people will find something. Does that something really result in something bad for majority of people? No, it does not. So there are other factors at play. Otherwise, we would be talking about myeloma occurring in 500,000 U.S. population rather than the 30,000 cases every year. It would be a very different scenario. So I don't know the particulars of your situation, but the likelihood is low based off of the number that you shared with me. And it's quite possible whenever you have a chronic inflammatory condition that you can see the kappa lambda ratio, kind of flipping. So, all right. How much time do we have?
Time for one more question, and we'll break for lunch.
Okay,
And if
all right.
you still have questions, so make it quick, I guess. If you still have
because
questions
we have
after,
people entering
we'll have a
for lunch.
Q&A session at the end.
Okay. I'm a caregiver for my husband, who was recently diagnosed with the multiple myeloma. But 2 years ago, he was diagnosed with CLL. From CLL, it went to smoldering multiple myeloma, and in a short while period, it went into multiple myeloma. Now, some of you ladies were questioning about back pain. My husband had a fracture in his back in April, okay? Meantime, he's being treated, coming for the CLL, and then during the tests and blood work, it didn't show that he had multiple myeloma, but they did a PET scan and saw they had a fracture on his back. So with that said, he had 3, this past Thursday, he had the kyphoplasty done. So that's the 3rd one he had done. My question is, if the blood work that he had done didn't show that he needed treatment at the time, how do we go from that? All of a sudden, you're getting all these multiple fractures, and it didn't coincide with that.
So again, I don't know the particulars of your husband's, case. So let me be very, clear. I'm not here to advise you on the particulars of what's happening to you. I will only provide generalization. I don't know anything about, your husband's situation. What I can tell you is CLL is a different condition. Myeloma, multiple myeloma is a different condition. People can have different kinds of cancers happening at the same time. It happens more frequently than we know. People can have skin issues and develop a blood problem. But even if you have CLL and multiple myeloma, you can have other situations as well. It's very common as we get older, regardless of whether we are postmenopausal women or older men, testosterone levels and essentially hormone levels go down, whether it's the estrogens or the testosterone. And bone loss becomes a very common thing as we age. So even if there are, CLL is there, smoldering myeloma is there, the fracture and the bone loss may be coming from a very different etiology or cause. So I don't know the particulars of this case, but it could be, I have patients, who got their treatment for multiple myeloma. They've been in a remission, but they continue to have bone loss because of other reasons and can develop fractures. That doesn't mean that myeloma is causing it. It's bone loss because of other reasons. I like I said, I don't know. I mean, I'm not your, husband. Yeah. Yeah, again, I cannot comment on the particulars of your husband's case. The medical advice part is not, something that I can do. I'm happy to see him and opine after reviewing medical records, but, this is not the venue for that.
But it is a sign.
It could be.